So now we're going to talk about the top 10 fluid articles in the medical ICU. The article that we're going to talk about is the SAFE study by Finfer, New England Journal of Medicine, 2004. So let's start with colloids. We're talking about 6997 critically ill ICU patients in Australia and New Zealand. This is 4% albumin versus normal saline for resuscitation. The 28-day mortality overall, no difference, 21% basically versus 21.1%. But the two subgroups matter enormously. The TBI subgroup, the albumin significantly harmful with a relative risk of 1.33, confidence interval 1.04 to 1.69. Higher ICP, worse outcomes. The sepsis subgroup, there was a non-significant trend toward benefit with a relative risk of 0.87. P-value was not significant, 0.09. This is the trial that raised the question that ALBIOS later tested directly. Albumin is neutral overall, harmful in TBI, and possibly helpful in sepsis. The colloid choice depends entirely on who's in front of you. The next study to look at is the ALBIOS trial. This closes the colloid question that SAFE opened. This is 18 patients with severe sepsis or septic shock in Italian ICUs, 20% albumin to maintain a serum albumin greater than 30 grams per liter, plus crystalloid versus crystalloid alone. We used milligram per deciliter, I believe, or gram per deciliter, so 3.0, getting the albumin up above 3.0 would be the goal. 28-day mortality, 31.8% versus 32%, no benefit. 90-day mortality, 41% versus 43.6%. P-value is 0.03. That was a marginal signal, but it was not the primary outcome. The albumin arm did show less net fluid accumulation, faster map recovery, and reduced vasopressor requirements. Septic shock subgroup, possible 90-day benefit, 43% versus 50%. But again, that was not the primary goal. Albumin doesn't clearly reduce overall sepsis mortality, but the septic shock subgroup signal is the most compelling colloid data that we have. So that's paper number 2. That's the ALBIOS trial. The next study we have is actually the crystalloid trio. Let's look at it as the Semler 2018 SMART trial, Finfer Plus trial in 2022, and Zampieri in 2021, the BASICS trial. So we move to crystalloids. This is the big one. 3 trials, escalating in size, asking the same question. Semler, that was actually 15,802 patients, New England Journal of Medicine. Vanderbilt study, make 30, 14.3% versus 15.4%. P-value was 0.04. It does look positive. Sepsis subgroup was the strongest signal of the 3 trials. Mortality was better in the group that had the balanced crystalloids, 26.3% versus 31.3%, p-value of 0.01. The plus trial, New England Journal of Medicine's 5,037, it was better blinded in a sicker population. 75% were on mechanical ventilation. 90-day mortality, 21.8% versus 22%, no difference, no AKI benefit either. It seemed to say balanced multi-electrolyte solutions are no better than saline. The BASICS trial earlier in JAMA 2021 is the largest. Well, it's actually not as large as the SMART trial, but 11,052 patients. Brazil 90-day mortality was 26.4 versus 27.2, no difference. The TBI subgroup possibly were harmed by the balanced solution. So remember the ALBIOS, the SAFE trial showed that albumin might be harmful in TBI. Here, BASICS trial showed that balanced electrolytes may be harmful. It was underpowered for that. So here's the pattern. As the trials got larger, more rigorous, the broad ICU-wide benefit disappeared. Only the SMARTS sepsis subgroup showed a clear signal. Balanced fluids help most in high-volume sepsis. Plus and BASICS found really no broad benefit. So, and you should consider normal saline in TBI. The next study is the FACTT trial, ARDS Network, New England Journal of Medicine, 2006. So this is volume strategy by disease state when we're starting with ARDS, 1,000 mechanically ventilated ALI, ARDS patients in the ARDS-NET protocol. So the conservative strategy was CVP under 4, wedge pressure under 8 versus liberal fluids. 60-day mortality no different, 25.5 versus 28.4. But conservative arm got 7 more ventilator free days, 14.6 versus 12.1. 2 more ICU free days. So cumulative fluid balance at 7 days was negative 136 versus positive 7 liters, almost 6992 cc's. There was no increase in shock or new RRT. This established this concept of going dry in ARDS, disease-specific strategy, basically keep the dry lungs. The next classic trial is actually called CLASSIC, and this is the Mayhoff trial in New England Journal of Medicine 2022. So these are going to be, the next 3 trials are going to be restrictive versus liberal resuscitation septic shock. This is in the ICU setting, 1554 patients, post-initial resuscitation, 31 ICUs across 8 countries, restrictive IV fluids versus standard care. Total fluids over 5 days, 10.4 liters versus 12.7 liters, about a 2.3 liter difference. 90-day mortality, 42.3% versus 42.9%. No different. Adjusted difference was 0.1%. No difference in days without life support, adverse events, or 1 year quality of life. Fluid resuscitation, fluid restriction post-resuscitation is safe. There was no harm, no dramatic benefit. So the concept is that you should individualize your care, not just flood them with fluids. The next trial is in the PETAL network, New England Journal of Medicine 2023. So now this is not like the ICU setting, the classic. This is in the ER setting. We're looking at 1563 patients in the CLOVERS trial with sepsis-induced hypotension, 60 U.S. centers. So the restrictive group got vasopressors first, limit fluids versus the liberal, which gave high volume before pressures over 24 hours. The first 6 hours, restrictive arm got 1 liter additional, liberal got 3.3 liters. The restrictive used more vasopressors, 59 versus 37%. 90-day mortality was essentially no different, 14% versus 14.9%, p.4. No difference in vent-free days or renal outcomes. So basically, don't reflexively bolus before pressors. Early vasopressors with less fluids is safe, not superior. That is the overall gestalt of the CLOVERS trial, the second leg of the restrictive versus liberal. The next is this ARISE fluids trial, just published in New England Journal of Medicine in June 2026. This is leg 3 of this trilogy, classic, CLOVERS, now ARISE. 963 patients, 47 sites, 3 countries, septic shock in the emergency room. Restricted fluids plus early vasopressors versus higher fluids plus later vasopressors. Tested for 6 to 24 hours after the initial 1 to 2 liters. Resuscitation primary outcome, days alive and out of hospital at day 90. Median was 76 days in both groups. Difference was 0 days. That's about as neutral as you can get. No mortality difference. 3 trials, 1 conclusion. You individualize, neither strategy dominates. So again, restricted fluids plus early vasopressors versus higher fluids plus later vasopressors really did not make a difference. It was 76 days in both groups. Another important study to know is the FEAST trial. So this is Maitland, New England Journal of Medicine, 2011. 41 children, severe febrile illness across 3 sub-Saharan African countries, albumin bolus, saline bolus, or no bolus. The no bolus was the control. 48-hour mortality, both bolus groups significantly higher than no bolus. Saline 10.5%, albumin 10.6%, and the control was 7.3%. The relative risk was approximately 1.45 for bolus. P was 0.003. Trial was stopped early for harm. So here the context does matter. There was no ICU backup. It was malaria. Anemia was prevalent. Different pathophysiology than the adult ICU shock. But the paradigm shift from 2011 was, hey, does the patient actually need a bolus? And we should know this paper because it really did change the concepts. Um, are we doing harm by giving fluids? And that started in New England Journal of Medicine 2011 with the FEAST trial. The FENICE trial is a practice mirror, not a randomized control trial. It's 2213 patients, 46 countries. The median fluid challenge was 500 cc's. 72% of cases had no safety limit defined. Dynamic preload indices were only used 22% of the time. Static CVP was still used 36%. Physicians gave further fluid in equal proportion, regardless of whether the response was positive, uncertain, or negative, ignoring non response entirely. So, the point of the FENICE trial was basically that we give fluids badly, reflexively, without endpoints. And now we're starting to teach fluid challenges more properly, looking at dynamic measures such as pulse pressure variation. We're looking at LVOT, VTI, things like that, not just CVP anymore. Another very important article, ANDROMEDA-SHOCK. This is basically in 2019. It's confirmed by the ANDROMEDA-SHOCK 2 trial in JAMA 2025. So we end where every fluid decision should end, at the bedside endpoint. 424 patients in septic shock on vasopressors. This is 5 ICUs in Chile and Colombia. The cap refill time of 3 seconds or less as the resuscitation target, as opposed to lactate clearance of 20% every 2 hours, which is what we typically do. 28-day mortality trended lower with cap refill time, 34.9% versus 43.4%. P equals 0.06. The SOFA improved more in the cap refill time arm at 8 hours, negative 4.4 versus negative 3.3, p-value 0.045. The cap refill time arm got less fluid, fewer interventions, and this was confirmed in 2025, the ANDROMEDA-SHOCK 2 trial, where we had 1,501 patients. The CRT guided protocol was superior. 1.16 was the win ratio. Not quite sure what that is statistically, but P was 0.04. It was driven by shorter organ support. So we should check the cap refill. If the cap refill time is normal, stop resuscitating regardless of the lactic acid. This is the endpoint that really ties our whole list together. And so the honorable mentions, we have the Rivers trial, early goal-directed treatment, New England Journal of Medicine 2021. This is basically the paper that launched the protocolized early resuscitation with CVP and SVO2 saturation targets. In hospital, mortality was 30.5% versus 46.5%. That was foundational. Ultimately, it was overturned. The next trials were Process, Arise, Promise, meta-analysis, PRISM, New England Journal of Medicine 2017. So that was a patient-level meta-analysis of 3,723 patients dismantling the Rivers protocol. The 90-day mortality was identical, 24.9 versus 25.4%. It eliminated the CVP and SVO2 targets from modern guidelines. The SALT ED, New England Journal of Medicine 2018, was a companion to the SMART in non-ICU emergency room patients, 13,000 patients, no difference in hospital-free days. Confirms balanced solutions matter most in the sickest, highest volume patients. Merrick CVP meta-analysis in CHEST 2008 basically showed that CVP did not predict fluid responsiveness. Pairs directly with FENICE and Rivers. The PPV, positive pulse pressure variation for fluid responsiveness by McCard, CHEST 2002. That was with pulse pressure variation greater than 13%, predicts fluid responsiveness in mechanically ventilated patients. And those are the honorable mentions. So really, that's the top 10 fluid management papers: colloids, crystalloids, volume strategy, endpoints. You should know your colloid, know the crystalloid, individualize the volume strategy, and always resuscitate to an endpoint, not a number on a bag. And thank you for listening.